Welcome to AETCM, the emergency medicine channel.
Yeah.
A 40-year-old female, non-case of hypertension, presented to ER which alleged history of DSH, deliberate self-harm, with conception of 30 seeds of Abrus precatorous with outer seeds in a powdered form.
Powdered form.
Powdered
Concept.
with outer seed cover intact.
Okay.
So 3 hours.
Outer seed cover was intact. Okay.
Powdered. She powdered along with the the seeds along with the outer seed cover.
Okay.
3 hours back.
Okay.
Initial 10-second assessment, airway is patent with no gargling of sounds, either hoarseness of voice, breathing, respiratory rate of 18 per minute, saturation of 99 with bilateral air entry present. Circulation wise, pulse rate of 100 per minute, BP of 120/70, saturation, all S1, S2 present, all peripheral pulse is palpable. Disability wise, GCS of 15/15 with a GRBS of 150. Exposure wise, afibrin. So we did an adjoint to primary survey. ECG was done, which shows sinus tachycardia.
What is the reason for taking an ECG in this case?
Abrus can cause cardiac arrhythmias.
Cardiac arrhythmias. Okay.
So
like for Abrus, she has taken 30 seeds now. So how is the toxic dose for Abrus?
So Abrus the toxic content principal substance is abrin. So 90 to 120 grams of abrin is toxic. That consists of 1 to 2 seeds, even fatal dose.
1 to 2 seeds. Is the 1 to 2 seeds without the outer coverage or with the coverage?
With the coverage.
With the coverage. And this patient has taken the whole thing as in powdered form. So most probably it will be in a large toxic dose, right? Okay. So how much time has 3
hours
elapsed after the injection?
3 hours. Actually, patient had the 30 seeds. Within 1 hour, they went to outside hospital. They given gastric lavage and then came here.
Gastric lavage was done. Okay. Okay. Any other adjuncts you did or just this one? Just ECG. Okay.
ECG, like basic blood works was also done.
Okay. So you can go with
secondary survey. 40-year-old female, non-case of hypertension, came to ER with from an outside hospital with alleged history of deliberate self-harm. She, due to personal reason, she went to outside hospital, given gastric lavage and came here for further evaluation. So at the time of presentation, patient complains of abdominal discomfort and nausea. There was no chest pain, vomiting, bleeding manifestation like hematochezia, hematemesis, melena, seizure, confusion or altered sensory. So there is no non-drug allergies. So
for Abrus, what are the normal clinical features that you can see?
Most common clinical feature include GI symptoms like nausea, vomiting, abdominal pain, loose stools. But it can also progress to severe symptoms as such. Hemorrhagic gastritis can also occur, which is the most severe form of gastrointestinal symptoms, which include abdominal pain, hematochezia, melena, hematemesis, and even perforation can also occur. So
any other symptoms? These are early symptoms include GI symptoms, and the early ones are abdominal discomfort, pain, these kinds. And later on we can have the hemorrhagic symptoms. And other systems which are affected in Abrus precatorous
cardiac arrhythmias can occur. CNS involvement, which are rare but can also occur in the form of hallucinations, seizures, CNS depression, cerebral edema.
CNS symptoms are mostly secondary to the hypovolemia, hypoxia that can occur, and cardiac symptoms can be primary and secondary as well. Primary because of the direct injection, and secondary because of hypovolemia. And renal symptoms
like hematuria can also occur. Renal failure can
also occur.
Most probably this GI symptoms in case of loose stools and vomiting, due to the persistent vomiting, it can cause hypovolemia, and even shock can also occur.
Diarrhea with the blood, right? Okay. And what are the metabolic changes that we can see in cases of in this condition here?
Persistent vomiting can cause hypokalemia, electrolyte disturbance.
Which are the electrolytes that mostly will be deranged here? Diarrhea is the most one of the diarrhea, and vomiting most probably. Sodium and potassium will be anyway changed. Most of the thing we will have to correct is hypokalemia. Management has to be done. Okay, go on.
So then in some cases ocular any dust in the eyes can cause ocular irritation and redness and even blindness can also.
What are the types of how can we ingest the Abrin?
Abrin can be taken as direct seeds or in a powdered form, it can be crushed and that extract can also be used.
Extract can be injected to the muscles. Then we can also inhalation injuries there. Then exposure to eye can cause conjunctivitis. And in most of the people used to take as oral dose.
So systemic examination, CVS wise, S1 S2 present with no murmurs. Respiratory system, bilateral air entry present with no added sound. Per abdomen there was a soft and non-tender. CNS wise, no focal neurological deficits. Pupils are equal and reactive. So patient was admitted under ER and in hospital patient developed multiple episodes of loose stools, this which was treated symptomatically. Then after 3 to 4 days, when there was no further symptoms, we discharged the patient with symptomatic treatment.
Can you explain what are the symptoms which occur, like early symptoms, late symptoms, like that?
Okay, most common early symptoms are GA symptoms. And
which occur within that usually within the 24 hours and it can go up to 3 days.
Then electrolyte imbalances can occur. Then ocular cardiac rhythm arrhythmias if GA symptoms was
systemic
not
toxicity can occur within the 3 to 5 days.
If there is no symptoms or patient is symptomatically better and or hemodynamically stable, we can discharge the patient in 3 to 5 days.
Okay. How about the renal symptoms? How we manage the renal symptoms?
Dialysis treat in end stage. First we can treat with most probably hypovolemia is the one causing the renal failure. So we can treat with fluids. If it was not becoming better and patient is worsening of renal failure is occur with anuria, we can even treat with hemodialysis.
Okay. Is Abrin a dialysable toxin? And Abrin dialysable? Abrin is not dialysable. We are dialysing just for for the other metabolic derangement and also for the management of the renal failure part. Abrin is a non-dialysable toxin. Okay.
So treatment wise is first thing is decontamination. If the present within 1 hour, we can give gastric lavage along with activated charcoal. Then other supportive treatment for that symptomatic management we can give.
What is the dose of activated charcoal?
50 gram. 50 grams the maximum dose. The 1 gram per kg, but maximum we can give up to 50 gram.
Okay. How about the time for the same?
Within 1 hour.
Within 1 hour. What about gastric lavage?
Gastric lavage is also within 1 hour.
Okay.
Then other supportive measures can.
In this case, we can
give up to 2 hours.
To 2 to 4 hours because sometimes they might not have taken us in a powdered form. Sometimes they might have taken us in seed form or crushed form. So it will take some more prolonged time for it. So we can give up for prolonged gastric lavage is also fine. Okay.
So then other supportive care can be given. If the patient develops convulsions, we can give anti-seizure medications. And renal failure, if it is severe, we will go for hemodialysis. And ocular exposure will irrigate the eye with running water.
Okay.
And other supportive measures.
Any other thing you want to say? Okay.